for class today, right? Even if you did not, I want you to please make a note that you need to go back and read this chapter. This is a lot of information, and there's a lot of exam questions that come from this chapter because it is very important. Okay? Let's see if I can get it to get full screen. Nope, we got the little sad face. Oh, there, what? Nice. All right. So, chapter 11 is all about cognition. So, when you guys went through your anatomy courses at UC or wherever you did them, did they review the areas of the brain and what they control with you guys? Briefly? Well, that's pretty much what you're going to get from me today is a very brief overview of it because it's going to kind of make sense if we talk about it that way. If you go to page 246 in your book, there's a little map in the top left-hand corner of the brain. It'll tell you like where different lobes, what they control. The frontal lobe is all about thought, memory, and behavior. You have the parietal lobe, which is language and touch. The occipital lobe, which is visual processing. The cerebellum, which is balance and coordination. The temporal lobe, which is hearing, learning, and emotions. And then lastly is the brain stem, which is your very, very basic stuff like breathing, heart rate, and temperature. Okay, so that little diagram, I want you to think about that as we're going through these different disorders today, and what areas are going to be affected. Okay, are we cool? All right, I'm going to assume we are. All right, so let's talk about cognition. What is cognition? Your book defines it as a mental action of acquiring knowledge and understanding it through thought. So it's taking in information and being able to reason through it. There are some different things that will affect cognition. There's acute conditions and then there's degenerative conditions. Your acute conditions are like your TBI from traumatic brain injury. That's pretty much when people say that someone had brain damage from an injury, from a car wreck, for stuff like that, it comes back TBI. A CVA or left CVA, that just means which side of the brain had a stroke. That's what CVA means. If a patient has a right CVA, they're going to act differently and have different deficits than someone who has a left CVA. For example, when someone has a stroke on the right side, their left side is affected. Okay? Someone has a stroke on the left side of their brain, the right side is affected. It's the opposite. Okay? Then you have an aneurysm. Aneurysms are a bulging or weak area of the brain in an artery that is supplying blood. When aneurysms become dangerous or deadly is when they bulge so far that they hemorrhage and then they get brain bleeds. It's a medical emergency and it will kill somebody very quick, depending on how large the bleed was. Then you have the arteriovenous malformation. That's a large word, AVM. Very simply means it's a entanglement of blood vessels in the brain. Even if it doesn't sound like a lot, it can have a lot of different side effects. One of them is ataxia. Does anybody remember what that is from 209? These are important terms to remember. They're going to keep coming up and up and up. So just loss of coordination and control. Look at you go. That's it. Loss of coordination and controlled movements. Then you have apraxia. You may remember what apraxia is. That's the loss of motor planning. You guys remember which test you did over in 209, which standardized assessment we used to test for apraxia? Yeah, look at you go, gold star. It was apraxia. That's Tulia. Very good. Then you have memory impairments. You can have slight to full dementia, hallucinations, different sensory changes. When blood vessels and stuff get tangled up in the brain, it can be a lot of issues. Then you have different degenerative conditions. And I've got videos. I'm going to choose to show them at the end just for sake of time. But you have Parkinson's disease. This is a motor system disorder, which is caused by the loss of brain cells that produce dopamine. That's important to remember. Then you have MS, or multiple sclerosis. This is where there's damage to the myelin sheath that disrupts nerve signals. So does anybody remember what the myelin sheath is? What it does in the brain? It's like a protectant layer, but it also is like, I like to think of it as a almost like a pool noodle around nerves in the brain. It helps protect, but also it helps keep things in order. So if a brain is sending a signal and there's diminished sheath there, it can break through and kind of go off to the side. It won't, make its pathway. It's what we see a lot with Alzheimer's disease too, the myelin sheath being it disrupts being able to send signals.
I'm sorry, can you say one thing that you said that was important?
That it's loss of brain cells that produce dopamine. Then you have ALS. This is a progressive disease. It is lifelong. Once it starts, it gets continually worse and worse. It affects the brain and the spinal cord, and it results in a wasting away of muscles. Has anybody ever seen somebody that has ALS? No? Yep. What's his name? Oh, God. Can't remember his name either. He gave the big speech about it.
On his last game.
On his last game, yeah. That's Brady's hero. Cannot remember what his name is.
Pete Brady.
Yeah. Then you have dementia. This, if someone says that somebody...
Lou Gehrig.
That's who it is. It's Lou Gehrig, yep. Dementia. It's not a specific disease. If somebody says that they have dementia, that can mean a lot of different things. And it can mean acute dementia. It could mean chronic dementia. It could be a bunch of different stuff. So it's a very broad term. According to the Alzheimer's Association, that about 60 to 80% of people who have some form of dementia also have Alzheimer's disease or some form. Then you have what's called vascular dementia. Vascular dementia is caused by a stroke. This is just simply where the brain is not getting enough oxygen from a stroke. All right. And then lastly, you have Huntington's disease. This is an inherited progressive disease that causes the breakdown of nerve cells in the brain. Okay. Cool. Now if you guys want to go back and watch them later too, I'm going to show them, but at the end of lecture, all of the links for the videos I'm showing you, like it's living with Huntington's disease and stuff, are right here in the PowerPoint. They're not on eLearn. There are some helpful videos and stuff on eLearn that. Okay. Cool. All right. So let's talk about cognitive rehab therapy. Cognitive rehab therapy has 4 big components that go with it. Okay. 4 big ideas, rather. The first one is to increase an individual's awareness of their deficits by first identifying their strengths and weaknesses through education. This is on page 249 in your book. The second part is problem resolution by retraining impaired cognitive skills. The third part is compensation for the impaired cognitive skills. And then lastly is generalization of the learned skills into real life, real world environments. CRT is very systematic. It's, very boom, 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 go down the list kind of therapy. It's very function oriented. I mean, this is huge for us. When we're talking about cognitive rehabilitation for all of these disorders, this is one massive area that we focus in. So this is a really important concept to get. So if you guys have questions, make sure you ask me, okay? Cool. So what is the role of OT? Why do we even care about CRT? First, we're going to do cognitive assessments and different adaptive trainings. Like teaching somebody, you guys have already done some of the interventions over there with cognitive rehabilitation therapy, and you didn't even realize it. I know one Isaiah did was the prompt of wearing things like, what should you wear, looking at the temperature, oh, this is what you wear. That's a strategy under CRT. It's trying to identify what their strengths or weaknesses are. Do they need something internal or external to help them? And we're going to talk about the difference between those two. You guys have been implementing it. You just didn't realize that you were. What do you think the OTA, not just occupational therapy, but what is our role as an OTA in CRT? Teaching the interventions. For who? The client and their family. That's the important part. A lot of these disorders that I mentioned, you're going to be training the family more than the patient because they're going to be there with them. Depending on your setting. I mean, if you're in a long-term care facility, it's you, and then you're going to train nursing staff. Some factors that can really affect how this works for people or how well it works is the severity of the disease. Are they in the beginning stages or in end stages? How they emotionally react to having this disease or disorder? Do they have a good family support system? Do they have any other comorbid diagnoses that are affecting? And then their ability to accept that they may have a disorder or a disease and being able to learn ways to cope. Are they even aware of it? Do they just want to forget that it's there, ignore it? Those kind of things. Okay. You guys go to page 251 in your books. So remember when I told you that there's like a ton of standardized assessments in OT, and we could spend your entire year teaching them to you. And one of the skills that we want you guys to understand is to know what is out there, but being able to learn a new test and read the instructions and being able to perform it. That's one of our biggest parts in level 1 field work is you'll learn a brand new standardized test you've never seen before. You'll get the instructions, you'll perform it on a patient or a virtual patient. On 251 and 252, there are several. The first one on there is the mini mental. You guys have done that one and you've seen it. There's several different ones. The Montreal Cognitive Assessment, Allen Cognitive Level Screenings, all these. But this is a really good chart to keep, print off, put it in your phys binders. If you see a patient is having difficulties with memory or difficulty with attention, this is going to tell you if that test is used for that. It's kind of a good checklist just to keep handy. Okay? Cool? All right. Let's talk about internal and external strategies. An internal strategy is something that is memorized and then we access it whenever we need it. Example would be like if you ever learned a song to learn the states and capitals to. A lot of people can say, oh, I learned that in elementary school, but the second the tune comes in, you can kind of, oh yeah, and I can do it right now. I'm not going to, but I could. from elementary school, the song that I learned the states and capitals to. It's like, that's still there. It's right there in the back of my mind. And I mean, it's an internal thing that we've used to learn these things. For an external tool, this is something that is external to the patient. So like a memory book, a orientation board, the blanket that Megan made last year, it's over above the sink, that would be an external tool. You know, the one thing you need to remember here, though, when you're choosing what type of strategy to use is if it is a mild impairment, you can use an internal strategy. If it is above mild, then you have to switch to an external strategy because people above a mild cognitive disability are unable to use internal. It just doesn't stay. Okay? Cool. All right. So attention and concentration impairments. Go to page 254 in your book. There are several different types of attention, okay? Attention itself is defined as being able to stay on task and be able to direct what you are focused on. The first type of attention is phasic alertness. This is like, it takes a split second to get your attention. Like if somebody wakes you up from a dead sleep and you're all of a sudden like, oh, okay, I'm in my bedroom or I'm on the couch, blah, blah, blah. Okay, TV's on. I know exactly where I'm at. That's your phasic alertness. Takes a millisecond. Boom, you got it. A response inhibition is the inability to direct your attention away from something distracting. You're unable to, like, you know, if I was sitting here talking to you and then I saw, you know, a plane flying outside and I was like, oh, okay. You know, I got to look. Next is your focused attention. This is the thought that is the most basic level of attention. If you look over on 255, there's a little triangle there. It goes from easiest at the bottom to the hardest at the top. Okay. Sustained attention, or the focused attention, is being able to remain focused on one task for an extended period of time. So focused attention is just being able to pay attention to something and not lose your focus. Sustained attention is being able to do that over a period of time. They're extremely close, so that's why they're kind of linked together as the easiest levels. Next is your selective attention. This is where you have the ability to focus on one item and being able to distinguish what is not important. So, you know, I might be over here and I'm like, hey, Lindsay, let's have this conversation. We're talking, but, you know, Faith and Allie's over here talking, and I don't really am paying attention at all to what they are doing. I'm focused on what we're doing, but I'm getting sensory input. I'm hearing them talk, but I'm not paying attention to it. My attention is not to what they are doing. That's selective attention. That's the next step up. Does that make sense? Okay. Then you have alternating attention. This allows for you to shift your focus back and forth between two tasks or activities. Both of them require thought. You know, what you guys are doing right now is alternating attention. Being able to listen to me lecture to you and you take notes. You're shifting your attention back and forth between your note taking and lecture. That's alternating. Okay? The next one, or the highest level, is divided attention. This is being able to simultaneously pay attention to two things, multi-stimuli at the same time. Okay? So I'm over here, Maggie might be telling me something and you're telling me something, and somehow I got both of what you're telling me. That's divided attention. Okay? That's very hard to do. So when you talk about somebody who has a cognitive disability, that is diminished. That is not, you know, easy for somebody to do. Some strategies. Definitely take note of that figure 11.3, that little pyramid, because that'll help you remember what is the easiest to hardest. Okay, cool. Some strategies there that are listed in your book that I think are awesome to help decrease, you know, distractions when you're addressing attention is alternate the environment to eliminate noise and distractions. Get them out of, like, if you work in a therapy gym, and, those can be very busy places, a lot of patients coming in and out, a lot of patients doing different things. Get them out of the therapy gym and take them to their room where it's a lot more quiet. If it is a noisy environment, cannot be altered, have them wear earplugs, which is totally fine. When fatigue sets in, take a break. We all get tired. Like, think about when you're studying and you're like, I've had enough of this. I need a break for a few minutes. That's the same thing with your patients. They're learning a new skill. Give them breaks when they need it. Don't complete a complex task when they're tired. If you have a patient who is not good with morning routines, don't do things in the morning with them that require a lot of attention. Likewise, if you have a patient in the evening that, somebody who goes to bed really early, which will surprise you, a lot of patients do. They want to go to bed by 6 o'clock after Jeopardy, and it's, it is what it is. And they're not going to do well on high attention oriented tasks because they're tired. That's the way their body works. Work slowly and focus on details, especially very important details. Double check their work for errors. Make sure that they're doing them correctly. If lost in conversation, ask for clarification. Sometimes you'll have patients that you don't understand what they're trying to tell you. It's okay to be like, what do you mean by that? Okay. If they're not unable to write down information fast enough, request that information be repeated. That's a good tip to give your patients, especially if you're giving like a home exercise program, and be like, if you don't know what this means, write it down. Get a good night's sleep, that goes without saying. And lastly, stick to routines. Okay? Any questions? So that APT model there at the bottom with that pyramid, learning that, if somebody has a cognitive deficit, that the divided attention is going to go away first. That's going to be the most difficult thing for them to do, all the way down to the sustained and focused. So when you're working on reattention or attention training with somebody, you need to make sure that they have that bottom layer first before you keep going up, and make sure that whatever intervention that you're choosing is appropriate for whatever level of attention that they already have. Does that make sense? All right, cool. All right, let's talk about some memory impairments. On page 257, there are some very basic types of memory. Like sensory memory. This is where you smell something and you're like, oh yeah, I remember this one Christmas that me and my grandma cooked an apple pie. And now apple pie makes you, when you smell it, you think of this memory. That's sensory memory. Or you see something and it's just familiar to you. You're like, wow, I remember that time where we did this, this, this. That's sensory. Short-term memory. This is referred to as the brain's post-it note. You can retain about 7 items for about 10 seconds to about a minute. This is very short term. When you ask somebody on that mini mental, like, remember these 3 words: car, red, notebook, or whatever you guys said. And then you test it again after a couple more questions. That's short-term memory. That's what you're looking at. Then you have what's called working memory. This is where memory or information is stored in your mind and manipulated. So you're using it to actively remember something. Okay. Long-term memory. This is a storage of information for long periods of time. Okay. Explicit or declarative memory. This is memory about facts or events. These memories are something that you can recall just kind of off the top of your head. Like, oh yeah, on my 7th birthday, I had a birthday party at the skating rink and Jimmy was there and it was a great time. Implicit memory. It's like a procedural kind of memory. This is where you remember, oh yeah, I put my socks on, I put my underwear on, then I put my pants on. those kind of things.
So for memory, are you using time?
Yep. Yeah, they definitely cross for sure. Then you have episodic memory. This is responsible for storing information about events that were experienced, like your first day of school. Like when I think of episodic memory, I kind of think of it as like a TV episode that you kind of like you're a character in the episode and you remember your like everything about that day. And then lastly is semantic memory. This is storing information about the world. And this is not, it's normally seen as like general knowledge, like the states and capitals or how a car works, you get the gas, go fast, those kind of things. Okay. So when someone is unable to remember things, we call that amnesia. And it's not just what you see on like movies where somebody gets hit in the head with a coconut and they forget everything about their life and who they are. And there's lots of different types of amnesia. Post-traumatic amnesia or PTA is a period of confusion that's like happens after a traumatic brain injury. At this stage or at a when somebody's having PTA, they cannot make new memories. That's very important to remember. You're trying to get them at this stage in therapy to recall things that they may have already known. For example, when my dad had a stroke, I would bring in pictures of people or show him pictures of people on Facebook and say, who is this? Or do you remember when your wedding anniversary is? Or what is your birthday? Do you remember your social security number? You know, things that are very basic that he should remember that most general people know right off the top of their head. Those kind of things. Very basic. You have retrograde amnesia. This is a loss of memory and events and information that occurred before the brain injury.
So like PTA would be like you went in to see your dad and you wouldn't remember, and then you went back the next day, you wouldn't remember yesterday.
More or less. Yep. Yes. The anterior, well, so the anterior grade, the next one, the anterior grade amnesia, that's more what you're saying. Like he wouldn't be able to make, no, I see what you're saying. It's like he didn't know me at all, like he had a stroke and then he didn't know me. That's the first one.
Yeah, I'm just thinking that cannot make new memories. So like
yeah,
you can't remember what you did with him.
Well, so PTA is strictly after like a TBI, any kind of traumatic brain injury. Retrograde amnesia is the loss of memory of things that happened before. Anterior grade is not being able to remember things after. So like he had a stroke, he couldn't remember, you know, what happened, anything before that, that's retrograde. Anterior grade is he had the stroke and now he can't remember what he had for breakfast by that evening. Those kind of things. Does that make sense? Between the two? Yeah, okay. All right, so again, with internal, we're going to talk about some different strategies here, both internal and external. Internal, you use with what? I talked about it a little bit earlier. You only use it with what? Yep, internal, mild. Only with mild impairments. Only mild cognitive impairments for internal. Some of the more internal ones are visualization, making a mental picture of information. These are all listed on page 258 too. Verbalization, repeating information over and over. Storytelling, by linking items together by telling a story about them. Association, mentally associating new information with something familiar. Organization is organizing items to remember them in a meaningful way. Categorization is organizing long lists by putting items in categories. Acronyms, I think you guys know what those are, right? Where you abbreviate first letter. Chunking information, we talked about that a few chapters ago. That's kind of like a phone number where you take little bits of information of the big picture, like 304 dash, and then three other numbers, and then dash, and then 4. It helps you remember. How many times have you like had somebody read off a phone number to you? You don't have a pen and paper to write it down, and you'll say it over and over. Like you can kind of remember the first 2 chunks, but then you repeat the last 4 numbers to yourself. You guys ever done that? That's chunking. That's a strategy that we use. Next is humor. I think a lot of people use this. You can remember something if it's funny. There's a lot of different things. Did she teach you the protraction, and retraction thing? How to remember it with the no? Protraction means no. Retractions mean we. Pro, no. We. No. Okay. Nobody gets it. Nobody gets that. Nobody got that with her? Wow. That breaks my heart. That was one of the funniest things Professor Hurt ever taught us. No. Protraction. Pro means no. Re means we. No. Wow. I went way over y'all's head. All right. Well, I'll keep going then. Rhyming is using rhymes to remember items. Okay. All of which are very mild. You're going to use these for people with mild cognitive impairments. Okay. External memory. This is things you're going to use with people over or anything over a mild cognitive impairment, like an orientation notebook or a memory notebook with a daily schedule in it. Electronic devices like cell phones, pagers, all these different things, voice recordings. All the way down to something kind of basic of a sign or a label. A lot of times you'll put signs on patients' doors that says, hey, this is Aetna's room. I'm like, oh, Aetna's room. I'm Aetna. I'm going to go in here. Even bright color signs. Green, it'll catch their attention. Those kind of things. Some helpful strategies to help are on page 259. That's keep distractions to a minimum and have the client focus on one thing at a time. Have the client keep to routines. Use a self-care checklist or a household management checklist. Keep household objects in the same place. Don't have them moving them around. Keep it as familiar as possible. Use labels or safety reminders like don't turn on the stove. That's a big one. You hear a lot of people scared that their loved one is going to burn their house down because they forget and they leave the stove on. That's a big concern for a lot of people. A lot of these kind of go without saying. I'm sure that you have thought of this kind of stuff with safety. Have you guys ever had to deal with an elderly family member or seen a family member deal with someone elderly in their home that was unsafe? Labeling things. Okay, here's the phone. I'm putting it right beside the door or right beside your chair in case you need me, call me, those kind of things. Very familiar, don't have to go all over the place kind of stuff. Okay? All right. Executive functioning impairments. Does anybody remember what executive function means? Isaiah, I haven't caught on you yet. You tell us what it means.
Executive functions, higher level brain functions, critical thinking, stuff like that.
Yep. So it's self-regulating control functions. This is how we organize our behavior. This is acceptable. This is not acceptable. Those kind of things. Reasoning through. How it's broken down, the two different types is organization and regulation. Organization is gathering information and preparing it for whatever we might need it for. Regulation is changing their behavior in response to what information that they took in. So organization is being able to take it in, understand what it is, and regulation is being able to use it at the right time. Okay? Go to page 260 in your book. There's some specific treatment interventions that are listed there for you guys. Our main goals of doing interventions with somebody when they have executive functioning deficits is to enhance their awareness of their deficits, make them aware of, listen, this is a problem. Another one is assist the client in anticipating or planning for difficulties. So being able to say that, this might not always be the exact same way. This is how we're going to plan to address that. Number 3 is address the patient's ability to execute whatever task is at hand. And then number 4 is assist the client in evaluating how well the task was completed. So this is getting them to understand, okay, I see that you got yourself dressed today, but, you forgot one sock. So that's a problem. You don't want to get blisters on your feet. Oh, yeah, I can see that. Okay, how can we make sure that we do that better next time? Those kind of things. Okay. Some techniques here are called, one of them is self-talk. That's talking through the steps of a task. Okay, so, you get up in the morning, you go to your closet. What's the first thing you grab? Okay, you grab your pants first. Okay, that's fine. No, you don't do that. Okay, what do we, walking through the whole task with the patient. Next is the goal, plan, do, review, the GPDR. That's where you have the patient write down whatever goal that they want to do. Okay, I want to, get dressed in the morning without any help. Next is identify the plan for accomplishing that. How are we going to do it? Are we going to make a checklist? How are we going to do this? Next is complete the task. Actually have them go through it with whatever plan that you made to help them reach that goal. And lastly is review it. Have them say, okay, did I do it? Oh, yeah, I did. I got both of my socks on this time. That worked really, really well. Or I still missed my sock. We need to do something else. Okay. The next one is predict and perform. This is a simple technique of having the client predict how well they will do on a certain task. And then have them say again, after they complete the task, how well they think they did. A lot of these are going to see overlapping strategies, from executive functioning, attention, memory. The big one that you're going to see that goes across all of them is limit distractions. If you have a lot going on in an environment, that's really going to inhibit somebody's ability to do whatever task you want them to do. Give them breaks. Don't do things when they're tired, those kind of things. Okay? All right. I'm going to go through these kind of briefly. I want you guys to remember to go over this table on page 262. It's table 11-2. There's a lot of different behaviors that are listed there. One of aggression is angry and hostile behavior. How long? And then it gives you an intervention right beside of it. As long as safety is not an issue, try to ignore the behavior or agree with them if possible to help diffuse the situation. Focusing on the root of the anger can help the client regain their sense of control. Going through these behaviors and knowing what they are going to be really important for your exam, okay? But it's just kind of basic memory stuff. Okay? One of the biggest things I do want to mention as far as us treating somebody who has behavioral impairments is we want to adapt either the intervention or we want to adapt the environment to be able to be, more welcoming for that patient. Okay? So when you think of behavioral impairments, think adaptation. Cool? All right, so awareness. There are 3 different types of awareness. You have what's called intellectual awareness. This is being able to identify that impairments exist. When we talk about awareness, we're talking about, do they understand that they have a cognitive disability or injury or anything like that? Are they aware that this is a problem? Because if they're not aware that it is a problem, that's really going to inhibit how well you're able to get into them and, have them get on board with treatment. And then you have emergent awareness. This is where they're able to identify the impairments as it is happening. And then lastly is anticipatory awareness. This is where they're able to anticipate, how much their impairment is going to affect them before it even happens. Why do you think that's such a big deal with successful rehab? If somebody's not really aware that it is an issue, why is it so hard to get them to understand that it is one? Or what can we do to help them understand that it is an issue? Allie?
I'm sorry.
Yeah, if somebody has poor awareness, they don't really understand that there's even an issue. Why is that such a massive deal on getting them to like jump on board with you for treatment? Okay. Okay. What else? Yeah. Like, why am I doing this silly puzzle game with you? Like, it's not a problem. I need to go to work. They may not have worked in 2 years. You know, this kind of thing. You know, if they don't have any kind of awareness, they're not going to be agreeable with you. If they're not agreeable with you, it's a whole other ballgame. Okay? Then you're going to get into those behavior problems. Yeah. So, what are some of these super complex disorders? Vision and cognition can both be affected in several of them. One of them is TBIs can affect vision and cognition. CVA, strokes, those are another big one. Infections is another big one that can affect both. ALS, MS, they all affect vision and cognition eventually. How do these disorders affect engagement in ADLs? Maggie? Yeah, before we watch the videos and you get to see like really what it's like, how do you think some of these, do you have any personal experience with any of those? Alzheimer's, dementia, any of those? Okay. Uh-huh. Yeah. It looks eerily similar, right? Yeah. It's crazy. Yeah. So how did that affect her ADLs? Couldn't do anything. Right. Affected everything, right? What about work? Somebody has a TBI at their job, or are now thinking about their job. They want to go back to work. How's that going to affect their ability to perform their job? Might not remember how to do it. I know that with my dad, he was a toll collector. So one of the things, his goal was to get back. He wanted to go back to work. I had him do like a play money set, and I'd be like, okay, there's different prices for different vehicles that come through. I'm like, okay, so you have a tractor trailer with 3 axles. How much is that? And he would go through and okay, I've given you a 20. How much change do you give me back? Playing these real world scenarios, now he's back at work. Those kind of things are huge and impactful because that's stuff that's ingrained in people's brains. The very most basic things that people can do. One thing I also did or do with a lot of patients is matching, recognizing that a 2 is a 2. I'll get a deck of playing cards and say, okay, lay them all out. Okay, here's this one, match it with this one. Okay, here's this one, match it with this one. That's very basic stuff. It gets the brain working again, and it's very bottom level kind of stuff. Keep those kind of interventions in mind when you're working with somebody. Pictures of common people or places or anything like that. This is where you talk to the family too and ask them, hopefully you can talk to some family about it. Like, hey, I'll bring in some pictures of their friends or their job or their house or things that they like. Run through them all the time with them. I always made my dad memorize his birthday and his wedding anniversary were the 2 that I always wanted him to be able to recall. And that was very early. I would go in and be like, Dad, what is your wedding anniversary? Oh, I don't know. No, give me a guess. And he would really think, and he would get really close, but he never would get it like right off the bat until later, until he got a little bit better. But he, getting his brain working on trying to think of the date of when his, that's working on a lot of different skills. It's not just him remembering that specific date. It's him remembering how many days of the month are there. It's him remembering roughly what year it might be because of, oh, that's been 30 years ago, so it's probably this date now. How many months there are in a year. Just thinking a lot of different things by just recalling a simple date, right? Think of those. So this is kind of like your activity analysis, breaking every little thing, the intervention that you're doing down at how many different areas you're working on with one thing. Makes a world of difference when you're talking about somebody with a TBI or a CBA or things like that. As far as different settings and different populations, how is cognitive rehab different for clients who have acute conditions compared to those who have degenerative conditions? What would you think? Somebody has, an acute condition like a CVA compared to somebody you're working with that has ALS. How would you approach that differently?
I think the acute would be more aggressive.
Okay, in what way?
I don't know, just like more therapy, like longer sessions.
Okay.
Just more often, I guess, and different.
Has anybody seen somebody who's had ALS besides a baseball player? Or had any kind of, so it's a slow progressive onset. Actually, when I was when I was trying to go to OT school up in Morgantown, I was doing some shadow hours and a patient came into the hand therapy clinic and me and him were hit it off. We were good friends. He loved WV football, and I love WV football. So we just talked and talked. Facebook friends now. He had a little twitch on the end of his tongue, and he had some problems with fine motor skills. That's why he was there. It's very minor stuff, but he wanted to get ahead of it. He ended up getting diagnosed with ALS and was in a wheelchair less than a year later. I mean, it was like, I say slow, but it's not like, boom, he was in a wheelchair. It was slow as in months, and it went down and down and down and down. It might have been longer than a year. It might have been 2 years. But now I see like who he was before. He was a contractor, had this booming business and stuff then. And then within a year, 2 years, he was, in a wheelchair and completely relying on his wife. It was pretty scary stuff. But how might you address, treatment for him knowing a diagnosis of ALS compared to something like sudden rapid onset like a CVA? Jennifer, you act like you want to tackle this question. Okay. Okay. That's a good point. That's a very good point. So with CVAs, you're kind of working for progress. With degenerative conditions, you're kind of working for planning. ALS doesn't get better. There's not a cure for it. It's a degenerative disease. You're kind of working for planning for the future and kind of in the moment stuff of things like, okay, well, your range of motion is really bad in flexion, but you need to be able to wash your hair. So we're going to throw in some adaptive equipment. Kind of, I hate to say it like this, but kind of like a Band-Aid therapy. It's not, you're making a world of difference, but you can't cure this person. And it's hard to come to terms with that. Like you're treating somebody who is not going to get better. Your main goal of therapy is to make their quality of life as best as it can be, right? If you're thinking, this is a pretty large question, but if you're thinking of wheelchairs for somebody with a degenerative condition and they're asking you what your opinion is before they order one from insurance, what kind of a wheelchair might you get for somebody with ALS? Don't overthink this. This is a large question, I know, for where you guys are at, but think about it. It's a degenerative condition. It's not going to get better. What'd you say?
I was saying like a modifiable one or a power one that could be modified.
There you go. Right. It's something that can be changed long term. They're not going to be able to use a standard wheelchair for the rest of their life. So probably looking at something like a power wheelchair or a standard wheelchair that can be modified for long-term use. Those kind of things, you have to keep that in mind when you're thinking about it, because insurances will only normally pay for one wheelchair over an extended period of time. And if they bought a standard wheelchair and then, in 3 months they're unable to use it, they don't care. They paid for one, they're not paying for another one that quick, and now they're kind of immobile. But if you get them a power wheelchair, it's a difference in thinking versus somebody with an acute condition. I want them to get a standard wheelchair because I'm going to eventually put them up on a walker and get them going. With a degenerative condition, you're not looking at it that way. You're looking at what's going to be a long-term use. Okay? We good? Cool. In what settings do you think you might see the different types of clients? You guys are really quiet today. Lindsay, where might you see some people with degenerative conditions?
Long-term care.
Long-term care. That's a huge one. A lot of people. A lot of people with degenerative conditions, though, you're probably going to see at home too, because they've planned for this. They know, like, their family member is not going to get better. We need to adapt the house. We need to put a ramp on. We need to do this so they can stay at home for as long as they can. I worked with a baseball coach who had ALS. Liked him. I mean, we were buddies. I liked to work with him a lot. And they did not adapt at all his house, and it drove me crazy. I got him way late in the game. I knew that strengthening really wasn't going to happen for him. That's what he wanted to work on. What was meaningful to him? I was more focused on adaptive equipment training with him, but I would do some exercises and stuff with him because that's what he was really wanting to do, to get his strength back. Made his day. And every now and again, I was like, you feeling good today? You feeling stronger? Like, yeah, I can do this. I knew it really wasn't any better. He might have a little bit more range of motion or something like that, but strength doesn't really come back. Where might you see some people with acute conditions? Faith? A hospital? Yeah. Where else? Acute can be, probably first 2 weeks-ish. A rehab facility, you're going to see a lot of acute conditions in rehab facilities. They're there to get better, to go home. Places like, used to be called Encompass, now it's called something, or it was Health South, now it's Encompass. Those kind of places, that you're going to see a lot of acute conditions. These are fresh strokes. Unfortunately, we're seeing more and more people come with acute conditions directly to home, which is stupid. They should never go from having a stroke in the hospital to going directly home. That's dumb. You're asking for them not to make progress and be relying on their family for the rest of their lives. It's always drove me crazy, but I'll get fresh strokes all the time on my home health caseload, and I'm like, we need to get you to a facility. I'm only here with you 2 or 3 days a week for 45 minutes. I'm not a miracle worker. You need to go to Encompass or to CAMC, general outpatient rehab, something where you're getting a lot of therapy. This is what, you have a very short amount of time to make the max amount of progress. But unfortunately, we're seeing a lot more acute conditions come into home health. So it sucks. I want to touch briefly on the group and individual treatment, why it's different. I don't like group treatments, especially when you're working with people with cognitive disabilities, because you're asking for distractions. What one person might need help with, another person might not need help with. And it's really hard to gear a group that will work really cohesively. Now, you might do a cooking group of people that have a stroke rehab group, and you want to do a pizza making group with them. That's fine. You just have to keep in mind that they all are probably at different areas in their rehab. All strokes are different. It's really hard to gauge it. I'm a huge fan of individual treatment. I don't like group treatment hardly at all, unless it's, like a cooking group or something like that. I'm all about one-on-one with people. Let's see. There we go. So I've talked a lot about the whole idea that you treat family members just as much as you do patients, especially with cognitive impairments. If you go to page 266 and 267 on your book, there's 6 good tips. First one is decreasing anxiety with education, making them feel comfortable that they can ask questions, and you want them to practice with you. I'm like, listen, it's going to be okay. I'm here. Ask me any questions that you need. Those kind of things. Always provide honest, thoughtful answers to questions. There's going to be some really hard questions, especially with the degenerative diseases. Like, are they ever going to be able to walk again? And you're going to be right there facing just them and their spouse and have to answer that type of question. How do you answer that? How would you answer it? You want to be as honest as possible with this is a definitely stepping on eggshells kind of moment. Because, you don't want to be like, no, there's no hope. My favorite answer to these type of questions is, I'm not really sure. I always say I don't speak in absolutes. I don't say they never will or they won't. I said, but I'm here to help them as best as I can. That kind of just throws it off to the side. But there's no easy answer to that. I always go back to the no absolutes thing. Like I don't ever really speak in absolutes. So, next is families need encouragement too. Always encourage them. Be like, yeah, they're even if with degenerative disease, like they are using a reacher today. Like they reached down, they got their clothes off the floor. Like we're going to work on getting them dressed independently next week. Encourage them that there's some hope there too. When I say to you guys that a degenerative disease does not get better, it doesn't mean their situation doesn't get better. It means their health does not get better. A lot of times you'll have people that have MS, ALS, these kind of things, and they're like, oh, my life is like over. No, it doesn't have to be. I can teach you a new way to do things. Just because you're not dressing the way that you used to doesn't mean I can't teach you a new way to get dressed and you're completely independent in it. Just because their health is not going to get better, they're going to continue health-wise to get worse, doesn't mean their situation has to suck and has to be awful all the time, right? And that's what our biggest focus is with therapy, is making their quality of life better anyway. Factor in their family dynamics. You know, do they have a lot of family? Do they have very little family? Are you putting too much on one person? Those kind of things. Don't throw a whole lot of information. I've often like given jobs to their kids. Like, okay, now, you know, you make sure that your mom does these exercises for me while you're gone. And okay, now you make sure that you don't let her, you know, cheat when she's putting her shirt on or her socks on or whatever. Make sure she's doing it the right way. You know, take some of that caseload off. No, you don't want to put anything major safety wise on a kid, but throw it off them and then just taking a little bit of weight off the spouse. Next is help families identify needs that must be managed. That's like the pressure sore education, stuff like that. They're like, listen, this is really, really important. This is kind of not negotiable. You have to check these kind of things. Let them know like the most important things. And last is give family permissions to step back as the client progresses. So like if you have somebody with a degenerative disease or you know, taking off of those and going back to the acute ones, the stroke, they're like, listen, I know how easy it is. A lot of us would drop anything and go take care of our family members because that's our number one people, right? But it's hard. It's really hard. And speaking from personal experience, it's really hard not to do everything for that family member. Very hard. You want them, like you're just a caring, you wouldn't be in this field if you didn't care about people and want to help them get better. But a lot of people don't realize that if they're just doing everything for them, that's not helping them get better at all. That's making it worse. You get into what's called learned helplessness, and then the patient doesn't get better for a lot longer when it could have been a lot shorter. So saying, listen, it's okay. Like he's able to put on his shirt now. Let him do it. Like I'm showing you right now. Let him do it. You don't have to do all that every morning. Let him do it. You know, you don't have to feed him anymore. He is able to do it. I got in this type of equipment. Let me show you. It's okay. Don't do it for him. Let him do it. You're doing too much. Those kind of things. Make sure you're educating the family members with that kind of stuff because that's going to inhibit your ability to help the patient get better if their family member is still doing all the stuff that you've now taught them to do. Okay? All right. Generalization. This is the idea. We're almost through. I promised them we're going to watch some good videos. It'll help make all this stuff tie together. This is where you're teaching somebody a new strategy or a new technique. They're able to use it across multiple platforms. So now they're able to not just get dressed at their home. If they go on vacation, they're able to get dressed in a hotel room. You know, you taught them how to bathe at home. Now they can go, you know, take a shower at their friend's house, whatever that it be. Those kind of things. Generalization, not just doing it in their own environment, being able to use it in the community and in other environments. Okay? All right. That's it. That was a lot of information. And I swear you really need to go back and read this chapter. Okay? Definitely things I was telling you, go through, highlight them, read them through. There are test questions on a lot of these. Okay?
There's only 2 questions.
No, there's not. There's 3. I got it. I promise. We got this one, which is an example of semantic memory. Next one is which is an example of selective attention. And on the next slide, there is OTA is treating a 23-year-old client who experienced a TBI. That sucks. No, this one's important. I don't know why it's not there. That's weird. Okay. I'll tell you what, since it's not on there, we'll answer it together.
Gonna get one square.
Yep, but you got to put it on your thing. Yeah.
All right.
All right. So OTA is treating a 23-year-old. Don't shout out the answer here. Has experienced a TBI. The client would like to re-enter the community and seek employment. Which symptom could potentially cause the biggest issues with future employment? Just think about it. This goes back to those behavior things that I just kind of touched on. But let's see if you guys can get it. Hang on, I'll go back.